Thank you for tuning in to the OSCE station. Today, we will be showing you how to do a quick and effective A to E assessment on a patient. This can be used in the initial management of an acutely unwell patient or for a general patient review. Starting with A, we first assess the airway and its patency. If the patient is talking, then the airway is patent. Listen out for any added sounds, such as inspiratory stridor or an expiratory wheeze. We also want to look for signs of airway obstruction. This could include a paradoxical chest and abdominal movements, otherwise known as seesaw respirations, and any use of accessory muscles. Consider an airway maneuver such as head tilt, chin lift, or a jaw thrust. You may want to escalate to a senior and insert an airway adjunct such as a nasopharyngeal tube, or if the GCS is less than 8, using a Goodell airway. Moving on to B, this stands for breathing. At this stage, you want to rule out any immediately life-threatening conditions, such as acute severe asthma, pulmonary edema, tension pneumothorax, and massive hemothorax. At this stage, you should assess the patient's respiratory rate and perform a focused respiratory exam, looking in particular for respiratory distress, noting any chest deformity, the trachea position, a hyper-resonant percussion note, and decreased breath sounds. It's important to measure the oxygen sats. These should ideally be maintained between 94 and 98%, unless the patient has a background of COPD where they should be maintained at 88 to 92, as high oxygen concentrations could depress breathing. If the patient has a new oxygen requirement, this really needs to be investigated, and you might think about requesting a chest X-ray. You could also think about doing an ABG and treating any reversible and life-threatening causes with appropriate treatment. This could be adrenaline for anaphylaxis, salbutamide for pulmonary edema. You should consider a stepwise escalation in oxygen therapy with bag mask valves or NIV. C stands for circulation. Here you want to assess the patient's circulatory state. Look at the colour and temperature of their hands. Look at the capillary refill time. This should be less than 2 seconds. It gives us an indicator of how peripherally shut down the patient is. Assess the pulse rate and volume and regularity. Assess the blood pressure and listen to the heart. Ensure one or more large intravenous cannula are inserted and take relevant blood. Assume hypovolemia is the primary cause of shock until proven otherwise, and a fluid challenge would be appropriate treatment at this stage. It's important to reassess the response to this. D stands for disability. Here, check the patient's glucose levels and ensure the pupils are equal and reactive. You can make a rapid initial assessment of the patient's conscious level using the AVPU method. A for alert, V for vocal stimuli, P for painful stimuli, or U, unresponsive to all stimuli. At this stage, you should also check the patient's drug chart for reversible drug-induced causes of low GCS. E stands for exposure and everything else which might be relevant to your patient's case. Examine the rest of the body for skin changes and bleeding sites. In summary, remember to assess and then treat any abnormal findings before you move on to the next step. Keep reassessing through the A to E to see if your management's helping, and if not, escalate to a senior, or if you need help at any point. Remember to always document your findings clearly in the patient notes and consider ceilings of care. Thanks for watching.